Tom, thank you. It has been a pleasure to work with Sea Change on this project. In fact, the Sea Change has just done the heavy lifting on this. Tom and his staff doing just yeoman work to bring us to this point where we have something to present as an initiative, and we can begin to move into next year to talk about how we can implement the initiative. So in 2009, the Institute of Medicine National Cancer Policy Forum had a workshop on assessing and improving value in cancer care. And obviously the pressures we just heard about in the last outstanding set of discussions, which sort of gives you pause as to whether we can really move the needle, but we're going to try. One of the issues that comes up over and over again is how one defines value. No one can be against it. How do you define it? Unfortunately, not too long after that, the health reform debate came along, and value sort of disappeared from the conversation. Cost became the focus. And once you start talking about presenting it in those stark terms, this costs too much, we should stop doing it, then the death panels and the rationing and the other crowds come out of the woodwork and make this a somewhat of an impossible task. So there's that endless spiral of going round and round about cost and rationing and death panels. And part of the problem in trying to define value is that in some respects it really cannot be precisely defined, because two people may look at this beautifully done, impeccably constructed and carried out clinical trial that shows that the standard therapy is the line, the straight line on the left, and the new therapy has a survival curve that looks like this. And some people may look at the median survival and say, well, that's a few months, 3 or 4 months of extra survival at potentially great cost and great toxicity, clearly not a therapy that we should associate with the word value. But then others will look at the tail of that curve and say that there are a few patients who have their lives extended substantially through this therapy, and obviously this therapy is of high value. And what we decided working in this group is that we weren't going to spend the next 10 years trying to dissect this and find the solution out of this, the values we bring to defining value. Instead, we said value is on a continuum, and there are things way at the left side, the low value, that just about everybody would agree this is pretty low value. And conversely, there are things all the way at the right side that just about everyone would agree is pretty high value. And we would try to concentrate our work at the ends of the spectrum. If we could show that we could make a difference at the very ends of the spectrum, where there's not a lot of controversy about whether this is worth it one way or the other, maybe we'll have the courage to begin to work back over time and try to cover the whole continuum. So we took as a goal, of course, to improve the quality of life of cancer patients, and concentrated on fully informed decisions and two very high value items of undisputable value: to increase the use of specialized palliative care services along with the primary cancer treatment, and to increase length of stay in which patients are enrolled in hospice, allowing that important and valuable therapy to be used more appropriately. We put together extensive case statements, and these are available. Clearly, palliative care has shown its value to be part of the entire continuum of a cancer patient's care versus the way it's often used now, which is at the very end when things are coming unglued. We know from high quality research that has been duplicated in many studies that a benefit of palliative care coming into cancer therapy early on is the side effect, if you will, is reduced hospitalizations, improved transitions of care, lowering the likelihood of unplanned emergency room visits and unplanned hospitalizations, improving greatly the quality of life, lowering symptom intensity across a broad range of symptoms, and while doing all these things, amazingly so, actually adding quantity of life, extending the lifespan of cancer patients. It's hard to say that this is not value in every sense of the word. Similarly, hospice care is being delivered far too late. About a third of hospice stays for cancer are 3 days or fewer. This is managing death and not managing the patient's last several months of life with family. 10% of patients enroll in their last 24 hours. It is impossible for a hospice program to grasp the case, the family, the dynamics, and so forth in a few days or even 24 hours. And hospice care is still often viewed as a very last resort rather than part of the continuum of care and part of the whole management process. So we have developed, we think, powerful case statements that summarize the science and the clinical science behind these initiatives. We've identified, although need to address, the culture and language issues. Oftentimes, patients are talking about, and patients and families are talking about, we need to do everything to treat the disease, and palliative care and hospice care is part of abandoning the fight to defeat cancer. You know, our sense is that we want to do everything to make your cancer care experience as successful as possible, not only from the treatment standpoint, but also from the symptom management standpoint, from the day you start treatment all the way through. We've summarized public opinion. We have a lot of work to do in reshaping the public's appreciation and remolding the public's appreciation of these services. And we've identified a need to overcome some of the public, professional, and system barriers, reimbursement barriers, barriers in professional care from oncologists who feel very deeply that they provide all of these services in their office just as a matter of course for patients going through therapy. And we know that the pros who do this full-time can assist us in doing it better. There are a variety of action steps that we can take. We have not completely decided upon an action plan. Next year is the year to move from the planning stage into the implementation stage. But we need to develop professional standards. ASCO is taking a lead in this. And then to assist professionals in adopting these standards and achieving goals. Empowering patients and families. We need somehow to begin to create a demand for this, not only through standards on the professional side, but understanding and requests on the patient side, to change the public mindset, to promote concurrent use of specialized palliative care and, when appropriate, hospice care with concurrent cancer treatment, and to support and merge efforts in similar work from other parts of the healthcare system. This is not a problem that is unique to oncology. So with that, our panel is going to present their points of view. We'd like the panelists to speak for about 5 minutes each, and that should leave us about a half hour for a lively discussion and Q&A and dialogue with you in the audience. So first, I'd like to call on Nancy Davenport-Ennis.
Thank you, Alan. So I would like to say to this audience that each of us at some point in our lives have already been a patient or may indeed be a patient. before we end this journey. I think that the death of Steve Jobs certainly reminds us that death is a change maker, and that when we are threatened by the diagnosis of cancer, that people have three very stark realities. Number one, the reality that this disease can be fatal. Number two, the reality that this disease may cause me to be very ill for a very long period of time, during which time I suffer from many symptoms, some caused by disease and some caused by treatment, and most culminating with pain. And as patients, we also realize that our lives are changed forever, personally, often professionally, and financially. Most of you have seen the same speech that I watched last night that Steve Jobs gave in 2005, when he reminded all of us that the diagnosis of cancer becomes a challenge for each of us, because now we begin to live each of our days very focused on what is genuinely important to each and every one of us. In our committee, what is important to us is moving this nation to a process where we understand that the integration of palliative care with hospice care is a step that needs to be taken from the day of diagnosis. In our committee, what is really important is that we begin to have a national dialogue to improve communication with providers and with patients from the moment of diagnosis, to explain what the entire continuum of care and the challenge of the disease may present to the patient. As we look at the value of cancer care, we understand that patients will assign value in a number of ways. And many of those ways include simplicity, management of pain, so that they are not living 5 years after a cancer diagnosis with 40% of them dealing with chronic pain issue, and that 60 to 85% of people diagnosed with cancer in advanced stages are not experiencing unmanaged pain every single day of their lives, and that 26% of our hospitalizations today are being driven by unmanaged pain. Value for patients is going to be defined in terms of their ability to remain at home with family, to remain a productive part of society, to maintain the simple act of mobility and independent living. We believe as a committee that indeed we can take significant steps to make those happen for us. We know that there are great giant steps that we together within Sea Change have an opportunity to take with all of the stakeholders who are represented. We know that it is not an easy step to move our cancer model from where we are today to where we would like to go in the future. However, we would like to challenge the audience in 4 areas. Number one, we would like to ask that we join hands and hearts to begin the education of the full continuum of cancer care, including the end-of-life discussion that integrates palliative care and hospice care from day one into the discussion, as early as middle school children in America. Many children in America have lost family members and have family members dealing with cancer. We would also recommend that the education has to be extended to the provider community to help them understand that it's not a matter of winners and losers. It's really a matter of how we live that process. Every patient wants to be a winner. Every patient wants to make their physician proud. Every physician wants to reach out and make certain that that patient has a good tomorrow and tomorrow and tomorrow. We would also encourage that we have to create a model of cancer care that rewards the hard work of dealing with families emotionally and practically through long discussions to help them understand palliation and hospice care and the role that that plays. So our committee sees that together, each of you in Sea Change have a wonderful opportunity to make a difference in this transition. We have the privilege at our organization of working with a very bright young man whose story I must tell you in closing, for he was diagnosed with a very rare cancer 6 years ago. For 6 years, he has fought valiantly, moving through 5 different clinical trials, the most recent being at MD Anderson. And what Mark has taught each of us is that when his doctors at MD Anderson moved him into a program in April that shifted him into palliation, day in and day out, to manage symptoms and pain and side effects, and moved him into hospice care in June to support his family, his children, his wife, and to support him. That day, he can take great joy in having a good phone conversation with you. Today, he can be excited that he's read a new book that was important to him. Today, if he could be here with you, he would say to you, stay the course, make this real for everyone, and help us all to understand our life does have value wherever we are in the continuum of the diagnosis and management of disease. Thank you.
Nancy, thank you very, very much. Dr. Morrison.
Good morning, everybody, and thank you so much for having me on the panel and having me here. I'm going to do something that I actually counsel all of my trainees not to do, which is speak both from clinical experience and from data and evidence, and I want to talk a little bit about that. Just to give you a little bit of an introduction, I am a palliative medicine physician by training, a health services researcher by occupation, and somebody who came into this field because of the dual experience of having two parents with cancer. In 1992, when I was a year away from finishing my internal medicine residency, my mother was diagnosed with inflammatory breast cancer. And as a healthcare professional, I knew exactly where that diagnosis was going to lead. I knew that the path was going to be very difficult, and I knew where it was going to end. She was a master's prepared high school teacher who was working on her PhD. A relatively spiritual person, very educated, and knew exactly where this disease was going to go. My father, a university professor, a psychologist, knew exactly what was going to be happening, and they all knew about hospice. They all knew about end-of-life care, and I knew that too, and I had referred many patients to that. I will tell you, throughout the course of that disease, my mother's goal was to live as long as possible with the best quality of life that she could, and she became a hospice statistic. She was referred within 3 weeks of her death. Why? Because at that point, it was the point where she couldn't get out of bed and she couldn't pursue life-prolonging treatment and couldn't be with her family. Now, as a profession, we think about and we talk about palliative care and hospice as if it's a continuum. And we talk about this as if one is diagnosed with cancer, and we should keep in our minds this dual possibility. The idea of pursuing life-prolonging or disease-directed treatments as long as it's effective, and then making a switch or a change or entering hospice early when treatments are no longer meeting those goals. The problem is, and the research that we've done recently doesn't support that. Patients don't think that way. And I think we need to start thinking about how do we meet our patients where they are. And I think we need to begin by thinking about what is palliative care. Dr. Lutcher presented all the data, some of which our group has done, that shows that palliative care truly enhances the value equation for patients with cancer. It is clearly associated with improved symptom management. It's clearly associated with improved quality of life. If you have advanced lung cancer, it's clearly associated with increased survival, and it is clearly associated with lower costs. So how do we ensure that our patients and their families begin to access it? Well, first of all, we need to meet them where they are. We conducted last year, or actually this past spring, public opinion surveys asking people, what did they know about palliative care? 90% had absolutely no idea what it was. When you define palliative care as team-based care focused on improving quality of life, addressing the needs of patients and families, provided an added layer of support, not replacing the doctor, not replacing the oncologist, not taking their place, but providing an added layer of support, and which is provided at the same time as both disease-directed and curative treatments. Over 90% of the American public say that I want this now, and I want it for me and for my families. 92% say that every single hospital in the United States should provide that level of service. And over 85% say that Medicare should cover it, and that ranges from Tea Party Republicans to liberal Democrats. So why is it that we aren't providing palliative care across the continuum? Well, first of all, we do have an access problem. We published a state-by-state report card yesterday. It's been a long day. I spent the entire day on the Hill yesterday talking about this with the A states, which showed that palliative care now is present in 63% of our hospitals, over 80% of those with 300 to 500 beds. So we're beginning to address the access problem. We have a workforce issue, and I think this comes to Alan's point specifically about what is the role of palliative care in oncology. I have heard a statistic, and tell me if I'm wrong, that in some parts of this country it takes 45 days for a woman newly diagnosed with breast cancer like my mother to see an oncologist. Okay. Fair enough? Why is that? Well, because we have successfully transformed cancer into a chronic disease. So our oncology specialists are not only providing disease-directed treatment, but they're taking care of survivors and they're taking care of chronic cancer care. I got to tell you something, folks. I am not an oncologist. I cannot provide chemotherapy, nor do you want me to. But what I can do is I can help people going through cancer-directed therapies and take care of survivors so that you, as the experts, can actually provide the disease-directed treatment. And I can work with you just like a cardiologist to ensure the highest level of care for your patients and your families. And I think that's the message that we need to do. What about hospice? Because we tend to talk about palliative care and hospice as a continuum. For those of us who are professionals in the field of palliative care, we see that as a continuum, because we do see that death is, in many, unfortunately, the natural endpoint. We saw that this morning with Steve Jobs. But the reality is our patients don't think that way. And we have been trying for 30 years since hospice was established as a Medicare benefit to convince our patients and our colleagues that death really is a natural part of life. And folks, we haven't done it. And we're not going to do it. Tolstoy was writing about this back in the 1800s, and we still haven't done it. So rather than think about this as a continuum within the public and with our oncology professionals, let's think about it as what it really is, that palliative care is provided at the same time as disease-directed treatments as an added layer of support. If we do that, and if we do that successfully, then at some point in the illness, because you have a team that has really been focused on the patient's values and goals, a team of oncology and palliative care, the appropriate patients will be referred to hospice at the appropriate time. We will get to the end where we want to go. But we need to meet our patients and their families where they need to be. That is true patient-centered care. And I think that's the role of both of these specialties, hospice and palliative care, in helping people with cancer. The public opinion research supports that. The data on value supports that. The data within our profession supports that. It's really hard to keep in mind the same thing, end-of-life care and curative treatment at the same time. It is really hard to keep those together, and we probably shouldn't. We should be keeping in mind, focusing on preserving quality for as long as possible and enhancing survival for as long as possible, because that's what our patients and families tell me they want. I mean, even as a palliative care professional, when I walk into the door of a patient with advanced cancer, they are not asking me to assure a peaceful death for them. They are asking me to help us live as long as possible in the best quality of life, and I think we can do that. And the best part about that is, and when we do that, when we truly match patients' values and goals to the treatments that we have available, we enhance quality, we reduce cost, and we get away from all of this discussion about death panel, and we enhance value. So let me end there, and I'm happy to answer questions during the panel.
Sean, thank you so much. And last but certainly not least, Linda House.
Good morning, everyone. I was asked to sort of come and give some comments from a systems perspective, and I'll do that through the lens of someone who's worked in the cancer field for almost 30 years now, so I have a little bit of a bias I'll disclose to you early in my comments. But I feel very blessed to be able to work, I think, in the system that really represents the ultimate collection of all of the systems in which you all represent. So I feel like my role here is to be a little provocative, to ask you to be thoughtful in the next steps that you take in helping us achieve this journey, which you've demonstrated we most certainly can. Leading a cancer center allows me every day to have the blessing to walk out and look at a patient, talk to a patient, understand what their family is going through, really understand what you all are working on and how that really touches this particular patient. Like I said, it is the ultimate conversion of your systems. Every day I'm asked to make decisions based on a number of what I call the comorbidities of our systems versus the confounding factors of our systems. One of the things that I say to my staff routinely is, I'd like for us to step back, because in fact, with an opponent as formidable as cancer, we have one choice, and that's to keep our patient as our true north. And the decisions and the thoughts that we put into those decisions have to be formed with that framework in mind. I raise that here because even as we were talking yesterday in our work group, we've come up, and you heard Tom describe those and Dr. Lichter describe those, we've come up with some things that we know we have to do. We know what the data shows, and around quality of life, around cost savings. We know that we have to educate, set standards, do those sort of things. But in situations like this, I think it's easy for us to default to what it is that we do best and start to make decisions and act on doing these things. And to the point of Dr. Morrison, and we didn't talk ahead of time, but not only do we have to meet our patients where they are, but I think we have to meet our stakeholders where they are. So how do we really do a strong analysis of understanding what do the systems look like? What are the drivers within the systems? What are the thoughts and beliefs and attitudes, so that we know how to then in turn change those behaviors? So that's one of the challenges that I have to you. In doing so, I want to remind you of two fundamental pieces of work that we all are very much aware of. Physicians, you've taken an oath to first do no harm. As other healthcare professionals, you know, when we're taught to do procedures and things, there are essentially rights. What are the right things to do? And I'll go back and date myself as a nurse. When I graduated from nursing school, there were 5 rights for medication administration. Right patient, right dose, right time, right route, and of course the right medication. I like to extend that medication to interventions, because we're not talking about drug therapy here. We may be talking about radiation therapy, we may be talking about placement of a clinical trial, we may be thinking about placement of a message, right? The right message to the right person at the right time. So when we look at our roles here and how we walk away from this meeting, I really challenge you to think about those fundamental principles. Number 1, do no harm, and number 2, how do you do the right thing at the right time in the right particular way? I want to share a story with you. It's a woman, her name is Jane. For those of you who are on the privacy panel, her name's not really Jane, but we'll call her Jane. Jane had a very aggressive form of melanoma. She was treated and completely blew through 3 different types of therapies, so the typical DTIC and interleukin-2 and interferons and all. Jane was discovered to be a BRAF carrier. She had applied for a compassionate use IND with the oral, from the oral BRAF agent. She came into the hospital dying, actively dying, and from this point on in this story, from this point until her death was a matter of about 4 days. The family insisted through conversations that they had had with Jane that she wanted everything done, and instructed the care providers to do everything possible, including the administration of this BRAF inhibitor, which was an oral therapy. Significant because as Jane was literally in her last hours of death, the request was made that an NG tube be put down, the medication be crushed, shouldn't be administered through that NG tube, because the message had been given that if she could get this drug, she would respond within 96 hours. Okay? That didn't happen. An NG tube was put down, the drug was crushed, she died within 8 hours of having her NG tube anchored. I share that with you because that is an example of broad systems failure. That's a systems failure from every one of us in this room. Drug company, systems failure, shouldn't have given the drug. Hospital systems failure, should have intervened when they should have. Physician systems failure, shouldn't have ordered that. just in a conversation. We should have had a conversation with that family a lot sooner, because in fact what we found out was Jane told her mother, do everything. Jane told her sister, I'm being strong for my mother. So I raise that with you as an example in closing, because I know that the people in this room can help me make sure that we don't have another Jane to talk about at our next meeting next year. I'm going to ask for you to do that in three specific ways. Number one, I want you to keep the patient as your true north. As you're making decisions, how do you do that through the lens of the patient? Number two, I'm going to ask us all to be quick, but not rush. So make sure that we make the right decisions as we're being quick in our response. And then in honor of Steve Jobs, and we've all referenced him today, I'm going to ask you to think differently. Think about how we meet our stakeholders where they are and bring our talents to that versus trying to push it through a top-down approach. And I look forward to being a part of that solution with you all. Thank you.
Linda, thank you. And we're going to open it up to questions, and I'm going to take the moderator's prerogative of asking the first questions while people organize their questions. Sean, there has been discussion in our group and around the country about the state of play in the palliative care specialty and the availability of practitioners, et cetera, et cetera. And one of the things certainly that I worry about is, in fact, that we're successful in getting this message out to everybody, and then the feedback comes, we're trying to do it, but there's no one in my community, or it's just not available. What is the state of the workforce, and how do you hope to address it?
Yeah, I mean, I think it's a very good question, because like oncology, palliative medicine is facing a tremendous workforce issue. That we don't have enough oncologists for cancer patients when we look at the future, and we don't have enough palliative medicine specialists for the future as well. So what needs to happen, and what are the strategies that need to happen moving forward? Speaking from palliative medicine, there are really three. The first is that because it's a new specialty that was established in only within 5 years, it's limited by the graduate medical education cap. That there are no GME slots for new fellowships in palliative medicine, and that needs to be addressed. Palliative medicine is the second fastest growing specialty behind hospitalist medicine, and what we're now seeing is really the best and the brightest coming into the field and dually training. So that in my fellowship program, for example, I have 3 fellows who are oncology boarded and doing palliative medicine, so they can do both. So we need to adjust the GME cap. We need to think about issues like loan forgiveness so that people have an incentive to come into the field. And then the third piece, which I think we need to do across the board, is to be able to provide a means for people in mid-career to learn the knowledge and skills of both specialist level palliative medicine and primary palliative medicine. And clearly the last piece is we need to think about how we do this as an interdisciplinary team, and the role of advanced practice nursing in the field, who can work with both oncology and palliative medicine specialists and to develop new models. I think it's a real challenge, Alan. You're absolutely right. But I think the status quo is unacceptable the way it is right now.
And Linda, I just want to explore for a moment the barriers and issues that hospitals and healthcare facilities face in setting up palliative care services. I remember at our institution, as we did most things, you know, it was a 3-year study, and reports were filed, and committees were impaneled, and on it went. How are hospital systems thinking about this? Have we passed through this? This is now just routine, or are there still barriers?
There are a lot of barriers, not only within the hospital systems, but within getting people to use palliative medicine. So we actually, in our system, one of our Commission on Cancer goals this year was to increase the percentage use of patients referred to palliative care. So we've tried to say to our physicians, look, we're going to uphold this as a standard for our accreditation and measure this at the end of the year, which has helped a lot to really get that level of buy-in. From an administration perspective, you know, we're very fortunate. We have a 770-bed hospital. Our palliative care team services, not just oncology, but our 2 heart hospitals and the entire continuum. But we have 2 board-certified physicians, a nurse practitioner, and a master's prepared social worker. We need help. You know, that's a big workload for those 4 individuals. So from a hospital perspective, you know, we really have to take a close look at some of those hard metrics, which are, you know, eliminating readmissions and the things that we don't like to think about versus what's the right thing to do for the patient. But it continues to be a challenge.
You know, it's interesting, and Sean, you know about this much more than I, but a paper from Mayo Clinic tracing their palliative care service and the utilization. And early on, it was, as it first got started, it was heavily used in oncology, but over time, oncology patients became the overwhelming minority of cases that were consulted upon by the palliative care service. And it seems that there's an embrace, it may be an embrace of this, at least in a hospital setting, from other services. You know, I think in part because oncologists feel they're already doing it, so they don't need anybody to help them.
I actually think it's twofold. I think that cancer has been the disease model for palliative care for many, many years. And I think that once a team is established and implemented in the hospital, you're right, the oncologists tend to be the first referrers. They're the early adopters. But palliative care is appropriate for any person with a serious illness. And eventually the others come along. And so actually at my hospital, what we've seen is that the oncology numbers don't drop a lot. In fact, they increase. But what happens is the others come up. So what we've seen is changing percentages, not changing numbers. The other piece, though, which I think is really key, is that because many palliative care teams are established in teaching hospitals, what happens is that the oncology fellows learn the basic principles of palliative medicine. And so, for example, in my hospital, you know, we get called for the really complicated pain cases in oncology, but we don't get called for the straightforward, simple ones anymore. We get called for the really difficult goals of care conversation, but the more straightforward ones have been role modeled and the fellows are taking it. And I think that's a really good thing.
Nancy, there's a lot of talk about communication. Dr. Morrison said, you know, if you say, you know, what do you think about palliative care? Most people say, you know, think about what? But if you say, what do you think about the services provided, 99% of people say, I want them. How do you think we begin to start communicating to patients, even to the point where we might create a demand from patients and families to say, I want this type of referral?
So I think part of it is semantics. I think we've used the word within the professional community of palliative care for years. I think we may, as a nation, need to rename palliative care, and in our committee meeting yesterday, we had a lot of discussion around that. I think we also, in the conversation with patients, there's some misunderstanding in the patient community that if they're going to move into palliative care, it may mean that they don't have their mental acuity. They're not able to communicate as thoughtfully. It might interrupt any ability to work in any capacity. And I think to the extent we can educate patients that palliative care is a tool to help manage a new stage of disease, and it is a tool that allows them to still have a degree of independent living and clarity, they're going to move for that, because what they do know is when the pain is unmanaged and the symptoms are unmanaged, that interrupts their ability to live a normal life at that point in disease.
Questions from the audience or comments from the audience? It's hard to see in the slides.
Alan, I'm over here.
Okay.
Hi, my name's Diane Meyer. I'm the director of the Center to Advance Palliative Care. And the first thing I want to say is how thrilled and moved I am to hear that advancing access to palliative care from the point of diagnosis is the top priority of the values subcommittee of Sea Change. So I could not have hoped for something like this 10 years ago, and it's a very powerful statement from your organization. The second thing I want to say is that with respect to the workforce, We will never have enough palliative medicine or palliative care subspecialists to meet the needs of every chronically and seriously ill person in the United States, even though we have data that shows that delivery of palliative care from the point of diagnosis improves outcomes, reduces cost, and may well prolong life. We have got to integrate generalist level palliative care into medical, nursing, and social work education. Those of you who work in hospitals, have ever been in a hospital, know that when you're admitted to the hospital, you are routinely assessed for fall risk or pressure ulcer risk or hearing loss by nurses. This does not require a doctor's order. If the nurse identifies that you're at high risk for falls, a protocol is put in place. It doesn't require a doctor's order. It's fundamental quality of care. My view is that nurses on admission should be routinely assessing patients for a range of palliative care needs: symptom burden, families falling apart, lack of understanding of the disease, questions about what the future holds, and that when those things are identified at admission to a cancer center, to a hospital, there should be protocols that kick in that nurses can be trained to carry out, and that only the more complex issues, symptoms that can't be managed by the primary team, difficult goals of care discussions that are going to take too long for the primary team, should rise to the level of specialty level palliative care. We have enough evidence to know what to do. It's just a matter of systematizing access and not waiting for the day that will never come where there's enough palliative medicine specialists to meet these needs. So I believe that's what cancer centers should be doing. Rather than saying, well, we can't do it because we don't have enough palliative medicine specialists to do what all our patients need.
First of all, I want to salute the committee and Sea Change in general for taking on this issue. The nation needs to have this discussion, and I think Sea Change is the appropriate organization to do that in partnership with ASCO. It's too important to be left to government. Yesterday there was considerable angst about not having a slogan antidote for death panels. But I would caution Sea Change and caution the committee that there's an entire shop here in Washington that does nothing but crank out terms like cut and run, tax and spend, other things that tend to dumb down a complex issue into a slogan to divert attention from the real discussion. So I wouldn't get too worried about that. But I would ask the rest of the committee their thoughts about the slogan business and whether it's the right way to go or whether we should charge ahead with the serious discussion.
I think it's a very good question, and I think I have two answers to that. I think the first is that if we continue to think about palliative care as switching into something, or a transition, or a point in the disease trajectory where you need it, then we get into problems of slogans. Because it draws a line in the course of a chronic illness between those living with the disease and those dying with the disease. And the reality is that bright line never exists. I think if we can begin to think about, which is what the public says they want, palliative care as just a routine part of care that starts not at a point where the disease has progressed to a bad point, but at the time of diagnosis, and is really just an added layer of support the way other pieces are. Then I think that we move beyond the death panel debate, the death panel slogans, the question about are we switching people over into a different system of care because they're dying? Because our patients aren't thinking like that. So we need to move beyond that. And I think if we do that, then we don't worry about death panels. It's not about us. It's about providing appropriate care during the continuum of an illness. And indeed, hopefully, some of our patients are going to be cured. Some of them are going to live for a very, very long time. You know, that has been the revolution in cancer care. But it really starts at diagnosis and is completely integrated across. The second piece comes to the name change. And you know, this is, as the former president of the American Academy of Hospice and Palliative Medicine, believe me, we have wrestled with this. The problem is that palliative care is an international specialty, and that's what the profession has decided, that's what its name is. You know, the good news is that, 90% of Americans have absolutely no idea what it is. So we can define it as we want for them. The bad news is that 90% of physicians think they know what it is, and they equate it with hospice and end-of-life care. That's the bad news. So we have both a public message and a professional message issue that we need to address. I'm willing to go the public route and call it what the public wants, but as a colleague of mine in Canada said, you know what, people eventually figure out they're getting good care and it doesn't matter what you call it.
And can I speak to that? Because
Please.
I have an opinion on this. A couple things. This is not Got Milk, and so when you think about the whole public campaign and the Got Milk campaign, this is not Got Milk, right? And true, the death panel tag caught on as well as the Got Milk, probably better than the Got Milk campaign did, unfortunately. But the reason that it really caught on is because that was a relevant message to a relevant group of people at a relevant time. So again, going back to my particular comments, this idea of palliative medicine isn't relative to the person who's healthy and jogging on the mall today. And because of the need to continually turn that message over, I think we have to be thoughtful. I do think we have to work on the public image. I do think we have to work on the educational campaign, but it's in a much different way than a broad consumer Got Milk kind of campaign. One of the things that I worry about is, for those of us who were around 11, 12 years ago when we did the first Harris poll on cancer clinical trials, and there was a really nice thought out, concerted effort to raise the awareness of cancer clinical trials, to dispel some of the myths, et cetera. We spent well over $15 million by my calculation to try to message people to not move the needle on participation in cancer clinical trials. And that's because if you're a woman sitting in the mammography center checking that box for her annual mammogram, you're not thinking that cancer is relevant to you. So those are just the things I think about when we're talking about, creating or talking to the general public is, again, it's got to be relevant before it's relevant, or it's a waste of a number of our resources that we could be using in a very valuable way.
Nancy?
And I think from the patient perspective, our comment would be that much as when our nation began to move from a fee-for-service insurance framework in the country, and everyone pretty much understood, I'm going to pay a flat co-payment, I'm going to have fee-for-service, I'm going to pay an established deductible. As the nation moved into managed care initially, few people understood what managed care was. They didn't understand the distinction between an HMO, a PPO, and there was a learning curve to make that happen. And we had to begin to change the language in order to do that. With palliative care, I think it cannot be reduced to a slogan. There always has to be the substance of what is palliative care, and the message has to be well defined for physicians and for patients. But I think the language that we use to deliver that information will make a difference in terms of how patients are absorbing it and how family members are dealing with it moving forward.
Yes, please.
Hi. A few years ago in Massachusetts, my name is Susan. A few years ago in Massachusetts, there was a regulation put in place by the state part of the Medicaid program that said that palliative care had to be paid for, covered, had to be a covered benefit at diagnosis for children because of the kinds of stress that a child's cancer places upon a family. And it just strikes me that one thing I'm not hearing here is there a systems barrier in terms of payment and time, payment for the time of nurses, et cetera, that is also impeding the progress that we're trying to make. Thank you.
So I would like to respond to that because indeed our organization, the Patient Advocate Foundation, collects extensive data annually around the issue of what are the barriers in terms of accessing health care in the country. And what we know is that when it comes to palliative care, there are huge variables depending upon which system you're in, whether you're in a Medicaid system, a Medicare system, a self-funded plan, in terms of what the reimbursement is going to be, if any, or the coverage. We also know that within the field of palliation, that step therapy is often used. and that indeed there are barriers that discourage appropriate levels of utilization, particularly of opioids, in managing late-stage disease and the pain that is incumbent with that stage of disease. And so we do feel that there are corrections that are going to need to be made within the coverage and reimbursement community at all of the payer levels to move this dial.
Sean, any comments from the community?
Yeah, there are a number of major barriers. And let me just sort of address them quickly. Why has palliative care grown in hospitals? Because that's where the business model has been. That palliative care teams are supported by a cost savings model within the hospital. The physician fees are reimbursed. So I bill Medicare just as an oncologist would bill Medicare, and my fees are reimbursed. I typically don't get enough to support my time because of the length of the family meetings, but that's another issue. My nurse practitioner is reimbursed depending on which state he or she works in. But my social worker, my chaplain, and the rest of my team is supported by the hospital, and that's based upon the fact that palliative care teams enhance the value equation, that they improve quality and they lower costs for hospitals. And on the average, a 300-bed hospital nets about $1.5 million for having a palliative care team. That model does not exist outside of hospitals. In the ambulatory care setting, there's not a business model to support palliative care teams. And so palliative care teams are leveraged, for example, the palliative care teams in cancer centers, the outpatient, it's simply a quality argument. That's a good argument, but it doesn't make a good business case. There is no business case in long-term care. So that there needs to be fundamental reform in terms of how these patient-centered services are covered. My personal belief is the ACOs, the accountable care organizations, patient-centered mental homes, bundled payments, all of these faith-based organizations cannot exist without integrated palliative medicine because it's those 10% that are going to be driving 60% of their costs. But there is not a mechanism of reimbursement right now that covers that team. Hospice, by contrast, is well supported through the Medicare benefit.
Well, Tom, we have another issue to take up. Obviously, since most cancer patients are many cancer patients never have to go in hospital, and I agree with you. The business model is there on the inpatient arena, but not on the outpatient. We have time for one or two more. If not, thank you. Oh, wait a minute. Boy.
So, great panel. Thoughtful. Good discussion. Lloyd Everson, McKesson, Medicine Oncology, Life Beyond Cancer. So, if you were going to play each of the panelists, Alan, and yourself, the role of one of the czars, I mean that in a positive sense, and you could make, 3 policy decisions that would really move the needle in this whole basket of cost and quality, what would you do?
Okay, Nancy wants to take that.
Well, only again because I am dealing constantly with reimbursement. So I'm going to give you the answer that we see now across 600,000 patients that we've served in trying to access health care and have been stopped due to some form of reimbursement. So I think we would say that, number one, we have to encourage the nation to move to the broad adoption of guidelines and to then indeed work within those guidelines within the community so that we are assuring quality health care that has been agreed upon by the brightest minds in the country in that particular area of therapy. And number two, I would think that we also have to encourage that the payers adopt those guidelines so that it's a consistent framework. And number three, that we educate patients that the treatment of cancer is not a hit or miss process, that it is a process that is used with collaboration across multidisciplines, as well as the agreed upon therapeutic intervention and long-term maintenance is agreed to by the entire team of people that have developed guidelines. To the extent that the payers adopt the guidelines, the physicians practice the guidelines, and the patients understand the role of the guidelines, indeed, I think we begin to move the dial on a more collaborative community with quality health care.
Can I get 2 policy and 1 regulatory? So the 2 policy. The first is that any new delivery model, accountable care organization, or bundled payment program, or patient-centered medical home, whatever the term du jour is, must include palliative care as a condition of participation. That's the first policy issue. The second is that we need fundamental NIH research for the care of people with serious illness, including cancer, focused on improving their quality of life. That we need a major initiative both at NIH and AHRQ to help develop the models of care and the symptom management and the communication skills that are going to help our patients and families. So those are the 2 policy. The regulatory piece, I think, is very straightforward. It's that every hospital and every healthcare institution has to have, both as Dr. Meyer said, a checklist for palliative care needs upon admission, just the way that they're required to have it for falls, for pressure ulcers, and that they have to have integrated palliative care within their program, just the way they're required to have an intensive care unit, just the way they're required to have an emergency department.
And I'm going to cry foul because it's hard to say it's a thoughtful group and then have us come up with 3 things just like that, but I'm going to give it a shot. Number 1, I would encourage the forward movement on personalized interventions and define interventions loosely, whether that's personalized medicine, biodiagnostics, that sort of thing. Number 2, we've got to continue to move the ball forward on patient-reported outcomes, and particularly in this area, what are those patient-reported outcomes? And that leads to the reimbursement piece. How do we right-side our reimbursement around what's important to the care of a patient versus what we can tag it to, minutes in a chair, whatever that is, days in the hospital.
And I think a lot of the action going forward is actually it includes guidelines, but it moves beyond guidelines, and has to deal with registries and a healthcare system and a cancer care system specifically that learns as it goes. If you look at the NCCN guidelines, which are rich and robust, and you ask, out of all the decision points, what is the percentage of decision points in cancer care through the NCCN that are based on level 1 evidence, that is high quality clinical trial evidence that pretty well establishes that this is the path to take? It's 6%. And so everything else is based on consensus, sometimes very high quality consensus, but consensus nonetheless, and moving down the chain. We have a huge amount of white space in oncology to fill in. Some of our consensus guidelines will turn out to be wrong, but we cannot understand that unless we collect the data on outcomes, both physician outcome and patient-reported outcome, and make the guidelines smarter in a process of continuous improvement. This feeds into this to this panel in the sense that as we create the guidelines that involve the use of palliative care, both specialty palliative care and understanding how to integrate best practice into individual patient encounters, we can actually measure that. We can actually measure the patient experience, and we can actually improve the system as we go along. Billing records don't do this. The federal government and CMS, it's fascinating. You look at CMS and their quality program in oncology. There are, in solid tumor oncology, there are 17 quality measures. We have, in our quality reporting program in ASCO, about 110 quality measures. We're barely scratching the surface in oncology quality. And Dr. Conway talked about the PPS exempt cancer hospitals that now have a quality reporting system. They will report on 5 quality measures. MD Anderson is going to report its quality based on 5 quality measures. So the ability to begin to transform this, to not keep reinventing the wheel, but band together as an oncology community and create this robust system is the future of oncology care, and that's my sermon for the day. With that note, I will thank everyone.